Root cause and trigger of my stroke. Clinical confirmation and VMT perspective. Number 1370, VMT sharp 711, September 27, 2025. Gerald C. EclaireMD Foundation. Category: Neuroscience and Stroke. Preface: I moved to the San Francisco Bay Area to work in Silicon Valley in 1976. Over the years, I relocated to 6 different cities, mainly to balance the demands of commuting between home and work. Each move led me to new hospitals and new doctors. In total, I have changed hospitals 5 times, and consulted with several different internal medicine and endocrinology specialists. Between 1977, age 30, and 2010, age 63, my health declined step by step. I first became overweight and then progressed to obesity, followed by type 2 diabetes, hypertension, and dyslipidemia. During this period, I also suffered 5 cardiovascular episodes, neuropathy, including a foot ulcer, retinopathy, and renal complications. By 2010, I finally woke up to the serious health dangers I was facing. This marked a true turning point. I left the high-tech sector, which had been a major source of my stress, abandoned my reliance on multiple medications, and adopted a strict lifestyle regimen. From that point forward, I placed my healthcare exclusively under the Stanford University system, which has maintained all of my health records since then. When I reflect on my health history today, I often look back to 1985, when my weight first reached 200 pounds, BMI 28.7, and to 1990, when my glucose was first recorded above 200 milligrams per deciliter. Those early years moving around explain why Stanford doctors lack any health records prior to 2010, and why so much silent damage had already accumulated. By the time I began my own strict lifestyle control, after having my stroke on June 21, 2025, it took me 3 following months of intensive self-study and research to gradually peel back the covering layers, and discover what really happened at the core of my recent crisis. Summary: after reading Dr. Schwartz's clinical letter, see attachment below, I find myself in full agreement with his description and with my own self-diagnosis. In my judgment, the first 20 years of neglecting obesity and diabetes management caused my irreversible cerebral microvessel damage, which was the true root cause of my stroke. Those bright white spots on my cerebral CT scan imaging I saw on September 11, 2025 in Dr. Schwartz's office confirmed what I had long suspected. The acute hypertension I experienced on June 21, 2025, a sudden surge to 175 mm of mercury, was not the cause but the final trigger. In engineering terms, the root cause was vessel damage from both diabetes and hidden hypertension, which behaved like a viscoplastic energy impact on my vascular system over 36 years. Through viscoplastic energy model analysis, I estimate that 91% of the damage resulted from the first 20 years of neglect, while only 9% came from the more recent 16 years of disciplined lifestyle. Because of this realization, I now monitor my body with scientific precision. 96 glucose readings daily through continuous glucose monitoring device, and 24 blood pressure checks daily. Producing 96 manual entries. Each test has SBP, DBP, PP, and HR. These measurements give me the best chance of detecting any acute hypertensive surge before it becomes catastrophic. I cannot undo the vessel damage accumulated during decades in the highly competitive Silicon Valley high-tech industry, but I still hope to extend my life a little longer in this beautiful world. Clinical observations from Dr. Schwartz. Dr. Schwartz's letter explains that my hemorrhagic stroke was mainly caused by long-term high blood pressure. He found signs of hardened brain arteries and damage in the small blood vessels, changes that usually come from years of pressure and strain. He did not think it was caused by a cavernoma, a type of blood vessel malformation. Instead, he concluded that the stroke was most likely a bleed from high blood pressure in a vessel, already weakened after decades of damage. This aligns closely with my own interpretation. The 175 mm of mercury blood pressure surge was simply a trigger. The real main causes were my earlier years of unattended obesity, BMI 32, and poorly controlled diabetes, hemoglobin A1c 12% during from 1990 to 2010. These factors damaged my blood vessels at both the macro level, cardiovascular events, and the micro level, renal disease and stroke risk. My root cause model. I interpret my stroke through the lens of viscoplastic medicine theory. The first 20 years of neglect, poor weight and glucose control, reliance on medications only without lifestyle discipline, contributed the vast majority of my cumulative vascular injury, about 91% of the viscoplastic energy burden. The following 16 years of strict lifestyle management added only a modest 9%, enough to leave some traces, but not nearly at the scale of the earlier 20 years. The final stroke was like an impact rupture. The sudden failure of a structure already weakened by long-term energy accumulation. This framing is consistent with both the pathophysiology of medicine and the energy models of physics and engineering. Vessels rarely rupture because of a single bad day. Instead, decades of accumulated stress gradually lower the threshold until one acute surge breaks the system. Quantitative allocation, 91% versus 9%. I calculate that 91% of my cumulative vascular injury came during the first 20 years of uncontrolled diabetes and untreated hypertension. During this time, irreversible scarring and stiffening of my microvessels took place. By contrast, only 9% of additional damage accumulated during the more recent 16 years, when my strict lifestyle management kept the disease largely in check, but could not erase the past scars. From a clinical standpoint, doctors cannot assign such precise percentages using MRI scans or blood pressure readings, but my physics-based VMT energy framework provides a way to quantify what conventional medicine can only describe qualitatively, integrating clinical and engineering views. From a neurological perspective, my stroke was diagnosed as a primary hypertensive hemorrhage in the pons. From my VMT engineering perspective, it was the endpoint of a decades-long energy accumulation process. These are not contradictory explanations, they are complementary. The clinical view explains what happened: a hemorrhage in a weakened vessel, triggered by a hypertensive surge. The VMT view explains why it happened now. The long-term cumulative energy burden had finally passed the rupture threshold. Together, they provide a more complete picture. Conclusion. In conclusion, my self-diagnosis is strongly supported by both Dr. Schwartz's clinical observations and my own VMT modeling analyses conducted since my stroke on June 21, 2025. Papers number 1308 through number 1366. Root cause: long-term vascular damage from poorly managed obesity, diabetes, and hypertension during my early 20 years. Trigger: the acute hypertensive surge to 175 mm of mercury on June 21, 2025. Framework: viscoplastic energy accumulation explains how decades of stress weakened my microvessels and predisposed me to hemorrhage. Dr. Schwartz's medical report and my VMT quantitative analysis are not two competing interpretations. They are two complementary views of the same reality. Attachment: outpatient letter, clinical notes. Outpatient letter signed by Neil Edward Schwartz, MD, PhD at September 18, 2025, 3:49 p.m. September 11, 2025. Dr. Kristen Sherman. Reply: Shu, Gerald. Dear Dr. Sherman, I had the pleasure of seeing your patient, Mr. Gerald Shu, in follow-up at the Stanford Stroke Center today, September 11, 2025. He comes to clinic alone today. This is the first time I have seen him since I saw him in the hospital in June. As you know, he is a very pleasant, highly intelligent, and active 79-year-old gentleman with a history of hypertension, diabetes, and hyperlipidemia who was admitted for a small right dorsal pontine hemorrhage. He had presented with a couple hours of right facial numbness and dizziness. Overall, we felt as though the hemorrhage was most likely secondary to hypertension. The patient was not really aware of chronic hypertension, but he has had periodic spikes of elevated blood pressure. He also had left ventricular hypertrophy on his echocardiogram. His vascular imaging demonstrated intracranial atherosclerotic disease, as is often seen in patients with hypertension. He did have a small right temporal lobe developmental venous anomaly, which brought up the possibility that the pontine hemorrhage could have been secondary to a cavernous malformation, as cavernous malformations and DVAs often run together. Looking at the signal characteristics, however, it seemed more likely a primary hemorrhage due to hypertension. We recommended a follow-up MRI scan that should be done shortly. Unfortunately, the patient came back into the hospital the following day, after having an episode of confusion. It sounds as though he was asking repetitive questions, and he was amnestic for a period of time. While there were similarities with transient global amnesia, he underwent an EEG scan that actually showed at least 2 left temporal lobe seizures. The patient was started on Keppra, which he has continued on. He has had no new spells. Lastly, he came back into the hospital at the end of August, after having an episode of severe fatigue after being on the toilet at the Stanford Mall. He was found to have a blood pressure of 105 systolic and was also bradycardic. The patient believes he was not eating or drinking much. He was seen by neurology and had a follow-up CT scan that was unremarkable. He recently had its CO patch placed, which he is now wearing. Mr. Shu provided me with a detailed multi-page document that highlights his recovery over an 80-day period, including data on cognition, memory, activity, and blood pressure. Overall, he feels as though he has improved quite a bit, but mostly has concerns about memory function. His current medications include amlodipine 2.5 mg, Keppra 750 mg bis in dye, Synthroid, metformin, and rosuvastatin 20 mg. His blood pressure is 129/63, his pulse is 69. He is afebrile. He weighs 77 kg. He is satting 100%. General, the patient is well nourished and well appearing. He answers all questions without difficulties. There is no aphasia. A neurologic exam was not done at this time. I had a nice discussion with Mr. Shu. I told him that likely the cause of the hemorrhage was, indeed, related to hypertension, versus less likely a cavernoma. The rest of his MRI scan does not show any other areas of microbleeds. He has a smattering of T2 weighted hyperintensities that are nonspecific, but commonly associated with small vessel disease. He has intracranial atherosclerotic changes as mentioned, but no evidence of carotid artery disease in the neck. I would like to get a repeat brain MRI scan to get another look at the brain stem, now that the blood has resorbed. Even if this was to be a cavernous malformation, I would not recommend surgery at this point, given he is asymptomatic and the deep nature of the area of bleeding within the brainstem. He will be seeing my colleague, Dr. Meter, in epilepsy next week. Dr. Meter may want to order an MRI scan too, more focused on epilepsy. I will coordinate with him whether we should order a specific protocol. The patient is interested in neuropsychology testing to better define what his current deficits are. I will go ahead and order that. I will plan on seeing Mr. Shu back in clinic in several months' time, to check on his progress and to go over his imaging. In the meantime, please do not hesitate to contact me with any questions or concerns. Sincerely, Neil E. Schwartz, MD, PhD, Clinical Professor, Stanford Stroke Center, Department of Neurology. Disclaimer: this content is for educational reference only and not medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be edited or republished as your own. All intellectual property rights and copyrights for this article and its related materials belong to the author, Gerald C. Shu.